Hello, my name is Ann Lee. Today we are going to be discussing the mental health of special populations. Our first population we are going to look at is the elderly and geriatrics population. Depression and anxiety are the most commonly seen mental health disorders among the elderly population. The increasing population of older adults is expected to reach 1.4 million for those over 60 by 2030. Along with coexisting physical disabilities or chronic health conditions, many older adults are at risk for developing mental health disorders such as depression or anxiety. The risk factors in the development of mental health disorders in the elderly population include social isolation, caregiver abuse, and loneliness. Looking at epidemiology for those elderly age 60 and over, it is estimated that 14% of those live with mental health disorders. Older adults account for 13% of the total suicide attempts within the US and about 24% of all completed suicides. Economic costs, the estimation of costs to treat depressive disorders in 2016 for those 65 and older was 9.8 billion. The breakdown equates to about 930 million out-of-pocket expenses, 1.4 billion from private insurance, and 7.4 billion paid by public insurance programs. Assessment and screening tools for the elderly and geriatric population include the Geriatric Depression Scale, or the GDS. The long form is 30 questions and the short form is 15 questions. They are yes or no questions, so they can be used with adults with or without cognitive concerns. The GDS 15, which is the short form, is recommended for use in outpatient primary care. The Patient Health Questionnaire, which is the PHQ-9, many providers use this to screen for depression in patients of all ages. However, it is not recommended for those with cognitive concerns, as it is not a yes or no answering system. The Depression in Old Age Scale, or the DIA-S, it is a questionnaire with 10 short statements with yes or no answers. Because of the simplicity of the questioning system, this screening tool can be used with those with cognitive concerns. We have the Cornell Scale for Depression and Dementia, or the CSDD. It is a 19-item screening tool for older adults with moderate to severe dementia. It takes about 30 minutes to complete and is completed by both the patient and their caregiver. We also have the Montreal Cognitive Assessment, or the MOCA tool. This is used to assess mild cognitive impairment and dementia. The completion of the screening takes less than 10 minutes and is the most common dementia screening tool used. Elderly and geriatrics treatment plan. Treatment decisions will be made based on assessment of suicidality, psychotic symptoms, other depressive symptoms, and malnutrition, assessment of the use of medication with depressant side effects or alcohol abuse, assessment of other medical conditions that may display depressive symptoms, assessment for a history of prior depressive episodes, along with the age of depression onset, prior drug therapy with outcome, and length of prior remission if achieved. Assessment for a family history of depression and family response to medication. Parents should be contacted or seen with patients, should be contacted or seen within 2 weeks of initiated medication to discuss tolerance, address concerns, and adjust the dose as indicated. Patients should have an office visit within 2 to 4 weeks of initiation of medication to assess for response, complications, or deterioration. The usual course of treatment is 6 to 12 months after achieving full remission to prevent relapse. Pharmacologic interventions. So second generation SSRIs, SNRIs, or NDRIs are recommended due to the reduced risk of side effects and safety. Medications are recommended to be combined with interpersonal therapy. SSRIs help to regulate the amount of serotonin that is active in the synapses between neurons. SNRIs address the levels of both serotonin and norepinephrine, and NDRIs regulate both norepinephrine and dopamine levels. Recommended medications are as follows: bupropion 150 to 450 milligrams daily, duloxetine 20 to 120 milligrams daily, escitalopram, which is the first-line treatment for depression, at 10 to 20 milligrams daily, paroxetine 20 to 40 milligrams daily, sertraline 100 to 200 milligrams daily, and venlafaxine 150 to 300 milligrams daily. Side effects of second-generation antidepressants are generally mild to moderate and can be tolerated or treated with over-the-counter medications. These side effects include nausea, headaches, and drowsiness. When looking at pharmacologic interventions, a provider should start the dose low at about half the dose of a younger patient, compensating for the decreased drug clearance in older adults, thus minimizing initial side effects and promoting compliance and maintenance with the medication. Collaborative interventions. Collaborative care consists of mental health specific case management. The team members should include specially trained nurses, social workers, and/or primary care physicians, being supervised by a psychiatrist. The collaborative team identifies concerns and provides guideline-based treatment, such as providing medication and medication monitoring for adherence and side effects, and proper mental health follow-up. Psychotherapeutic options include group cognitive behavioral therapy, or CBT. This type of psychotherapeutic intervention focuses on how emotions and behaviors work together in everyday functioning, and how changes with one of them can affect or improve others. The goal is to modify the unhelpful emotions and behaviors that typically impair functioning. This type of therapy is delivered in a group format over 7 to 15 weekly sessions. The next is interpersonal psychotherapy, or IPT. This type of psychotherapy is a patient-specific individual therapy with the goal of learning strategies to appropriately communicate emotions and needs to help build positive and strong interpersonal relationships. There is a strong emphasis on learning the relationship between the effects that negative events have on their feelings of sadness and worthlessness, thus exacerbating depressive symptoms. And finally, group life review and reminiscence therapy is a psychotherapy treatment where older adults can share their stories from childhood to the present moment in a group setting to help them cope with the transitions that occur later in life. The average number of sessions is 4 to 12 weekly group sessions. Our next is the perinatal or lactation population. Perinatal mental health disorders can lead to significant maternal and fetal infant morbidity and mortality as a common complication of childbirth. Looking at epidemiology, hospitalization is required for around 1 to 2 in every 1,000 women for the first few months after giving birth due to episodes of severe mental illness. Studies have shown that women are 22% more likely to have a psychiatric admission in the month following birth than in pre-pregnancy period. Studies have shown that 20% of women go through a severe postnatal mental illness if they have a pre-existing bipolar condition. Following birth, it has been found that for every woman who requires psychiatric admission, 2.5 women need outpatient treatment, and 12 women receive pharmacological treatment through their primary care provider. Based on studies completed, about 17% of women experience postnatal depression. There is a prevalence rate of 15 to 20% for antenatal and 10% for postnatal anxiety disorders. Looking at economic costs, the cost of perinatal mood and anxiety disorders in the U.S. Economy is estimated to be about $14 billion from conception to 5 years postpartum. The average U.S. lifetime cost annually for perinatal depression is estimated to be over $45.9 billion. And $31,800 is the average cost for each mother-child unit from conception to 5 years postpartum annually. All right, assessment and screening tools used for the perinatal and lactation population. So depression screening can be completed with the PHQ-9 or the Eidenberg postnatal depression scale. Bipolar disorder can be screened using the bipolar disorder MDQ screening. Anxiety should be screened with the GAD-7 screening form or the perinatal anxiety screening scale, otherwise known as PASS. And PTSD should be screened with the PC-PTSD-5 form or the PCLC form. Treatment plan for the perinatal and lactation population. Medications may need to be increased above the usual therapeutic range in late pregnancy in terms of pharmacological interventions. Providers should start the lowest effective doses and minimize switching medications that were pre-existing to the pregnancy. If a patient finds the medications sedating, they should be switched from AM to PM. There is a medication called brexanolone. It is given via IV infusion over 60 hours. And this can be used for moderate to severe depression with onset in late pregnancy or within 4 weeks postpartum. The first-line treatment for mild, moderate, or severe depression, anxiety disorder, or PTSD includes sertraline starting at 25 milligrams in the morning, increased by 50 milligram increments after 4 days, and then 7 more days. This medication has the lowest degree of passage into breast milk compared to the other first-line antidepressants. The next option is fluoxetine, starting at 10 milligrams every morning, increasing to 20 milligrams in 4 days, and then increases by another 20 milligrams after another 7 days. Citalopram can be used at 10 milligrams every morning, then up to 20 milligrams after 4 days, and then increases by another 10 milligrams after another 7 days. The side effects for this medication include QT prolongation, so avoid in those with already having cardiac concerns. Escitalopram can be used starting at 5 milligrams every AM, increasing to 10 milligrams after 4 days, and then increases by 10 milligrams up to 20 milligrams after another 7 days. Side effects for this also include QT prolongation, so again, avoid with those patients with cardiac concerns. Second-line treatments for mild to moderate or severe depression, anxiety disorder, and PTSD include duloxetine. This may need a higher dose in the 3rd trimester and when treating anxiety disorders. Venlafaxine, fluvoxamine, and paroxetine can be used. Collaborative interventions for the perinatal lactation population can include should include the obstetric clinician to be the primary prescriber of the pharmacotherapy, with the psychiatrist serving primarily in a consultative role. Behavioral care manager is key to the collaborative care, and the program's success is tightly linked with this role. The care managers are behavioral health professionals, often clinical social workers, psychologists, or nurses by training, and serve as a primary contact point between the patients and obstetricians alike. Psychotherapeutic options include cognitive behavioral therapy that is modified for postnatal depression and can be used for postnatal anxiety, interpersonal therapy, and listening visits as well. Our next population is going to be the pediatric adolescent population. Children and adolescents commonly suffer from emotional disorders, behavioral disorders, and eating disorders. Emotional disorders most commonly consist of anxiety and depression. Behavioral disorders most commonly consist of ADHD and conduct disorder. Eating disorders most commonly consist of anorexia and bulimia nervosa. Another behavioral cognitive disorder that is common is autism spectrum disorder. Looking at epidemiology, for children and adolescents aged 3 to 17, it's noted that about 20% have a mental, emotional, developmental, or behavioral disorder. For high school students, it has been shown that suicidal behaviors increased by more than 40% in the decade before 2019. The number of adolescents aged 3 to 17 diagnosed with depression increased by 27% between 2016 and 2020, as shown by the study conducted by the Health Resources and Services Administration. It is estimated that 3.6% of 10 to 14-year-olds and 4.6% of 15 to 19-year-olds experience an anxiety disorder. Depression is estimated to occur among 1.1% of adolescents aged 10 to 14 years and 2.8% of 15 to 19-year-olds. Economic costs, the average total cost per episode for publicly funded outpatient services for youth mental health issues was $2,673. The average cost of various service types per episode was $1,079 for psychotherapy, $683 for assessment, $227 for collateral services, and $161 for case management, and $186 for medication support. Assessment and screening tools for the pediatric and adolescent population. We have the Columbia Depression Scale, or the DCS. This is a 22-item self-report that screens adolescents age 11 and up for both depression and suicide. The questions focus on feelings and behaviors over the past 4 weeks. The Center for Epidemiological Studies Depression Scale for Children, or the DSC. This is a 20-item report for children and adolescents age 6 to 17 that screens for depression. Questions focus on feelings over the past week and take about 5 minutes to complete. We have the Spence Children's Anxiety Scale, or the SCAS. This is a self-administered 44-item tool used to screen anxiety symptoms in school age and preschool children for 6 kinds of anxiety, including generalized anxiety, panic and agoraphobia, social phobia, separation anxiety, obsessive compulsive disorder, and physical injury fears. The Strengths and Difficulties Questionnaires, or the SDQ, is a self-administered behavioral questionnaire that screens children and youth ages 3 to 16 using 25 items on 5 scales. This is emotional problems, conduct problems, hyperactivity and inattention, peer relationships, and pro-social behaviors. This is completed by the teachers and parents. Treatment plan for the pediatric and adolescent population. So upon initially being prescribed medication, the adolescent will likely see the prescriber at least a few times within the first 8 weeks to check whether they are taking the medication as prescribed, as well as to determine whether the dose is optimal and whether the adolescent is experiencing any adverse side effects. Once the adolescent has a stable medication dosage and reports a decrease in symptoms, visits to the prescriber will likely be less frequent. Pharmacologic intervention. So when looking at depression, recommended first-line treatment is fluoxetine, 20 to 40 milligrams daily over other medications due to safety concerns with other medications. This SSRI medication helps to regulate the amount of serotonin active in the synapses between neurons. Side effects include headaches, nausea, and drowsiness as mild and tolerable side effects. Severe side effects include suicidal ideation and may require altering the dose or discontinuing the medication. Looking at conduct disorder, medications are not often used for this disorder itself, but medications to treat comorbid disorders or symptoms, such as ADHD, can be used. When looking at anxiety, selective serotonin reuptake inhibitors, or SSRIs, are used as first-line treatment, either in combination with cognitive behavioral therapy or alone. So again, we're looking at the fluoxetine or escitalopram. Options include fluoxetine, escitalopram, sertraline. Duloxetine may also be used for those children with generalized anxiety disorder who are 7 years or older. Looking at ADHD, we have the option for stimulants as first-line treatment options. They do have the potential for addiction and abuse, however. You should use caution with patients with a seizure disorder as well as those with pre-existing psychiatric illnesses. Options for stimulants include methylphenidate, dexmethylphenidate, lisdexamfetamine, dextroamphetamine, amphetamine. Side effects can include decreased appetite or sleep problems. Non-stimulants that can be used is atomoxetine or guanfacine. These medications do not work as quickly as stimulants, but they can last longer for up to 24 hours. And looking at autism, so psychopharmacotherapies do not treat the core symptoms of autism. Medications are often used to treat behavior or comorbidities, such as ADHDs. However, melatonin between 1 to 10 milligrams can be used nightly, about 30 minutes prior to bedtime, to help with sleep latency and duration. Collaborative interventions. The goal of collaborative care is to conserve the scarce specialty care providers for severe and complex psychiatric disorders. To do this, they shift certain specialty mental health tasks like assessment, patient self-management, brief psychosocial intervention, basic psychopharmacology, and care coordination to primary care. The integrated care multidisciplinary team-based approach has the strongest evidence base in improving clinical outcomes and patient satisfaction while limiting costs. It is necessary for supporting activities for effective collaborative care. This to include the patient and family engagement, professional education and training, evaluation and demonstration of impact, fiscal sustainability, and advocacy for model dissemination. Psychotherapeutic options. So looking at depression, we have the cognitive behavioral therapy. This focuses on how thoughts, feelings, and behaviors are intertwined in everyday functioning and how changes in one domain can lead to improvement in another. It can teach adolescents to differentiate between their thoughts and feelings and regulate their feelings by questioning their assumptions and beliefs. There's also interpersonal psychotherapy for adolescents, which aims to improve the person's relationships with others by learning strategies to communicate emotions effectively and needs and problem solve within a significant relationship. The IPT focuses on grief, interpersonal role disputes, role transitions, and interpersonal deficits. Conduct disorder, we have cognitive behavioral therapy, learning to solve problems better, communicate, and handle stress. This also helps to learn how to control impulses and anger. Family therapy is used to help improve family interactions and communicate skills. And peer group therapy is used to develop those skills to interact socially. Looking at anxiety. We have cognitive behavioral therapy as the first-line treatment for anxiety. This can be used as monotherapy or in combination with medication, and is used for mild to moderate symptoms. ADHD, behavior training is used for both the parents, for management, and for the children. This is a first-line treatment before medication is tried. And autism, we have early intensive behavioral intervention, or EIBI. This is the gold standard of autism treatment. It is intensive education using applied behavioral analysis techniques. Treatments are aimed at alleviating core symptoms like occupational and speech therapy, social skills, and cognitive therapy. Music therapy can also be used, but it does have a limited application. Our next population is going to be the LGBTIQ plus population. LGBTIQ plus stands for lesbian, gay, bisexual, trans, intersex, queer, or questioning. LGBTIQ plus patients are noted to experience depression, self-harm, substance abuse, and suicidal thoughts more commonly than those that are non-LGBTIQ plus. Discrimination, homo and transphobia, social isolation and rejection, and difficult experiences with coming out can all contribute to a negative effect on their mental health. The experiences with being LGBTIQ plus are what contribute to negative mental health, but not being LGBTIQ plus themselves. While there are focuses on the negative aspects associated with being LGBTIQ plus, there are positive effects on their mental health as well. This includes building confidence with oneself, a sense of belonging to a community, improvement in one's self-acceptance, and improvement with relationships with friends and family. Looking at epidemiology, 50% of the LGBTIQ plus community have experienced depression and 60% have experienced anxiety. 12.5% of the LGBTIQ plus community have attempted suicide. About 50% of trans people have contemplated suicide. About 86% of LGBTIQ plus youth aged 11 to 17 were screened positive for a moderate to severe mental health condition, leading this group to have the highest rate of all LGBTIQ plus individuals. 89% of transgender screeners screened positive for a mental health condition. 50% of all LGBTIQ plus individuals reported significant thoughts of suicide or self-harm, compared to the 33% of non-LGBTIQ plus individuals who screened positive for a mental health disorder. And 33% of those LGBTIQ plus individuals who screened positive for a mental health disorder did not want follow-up after screening, and 17% reported that they did not want treatment. Looking at economic costs, due to the limited evidence and research currently, what we have found is that $650.16 million is the total annual cost for conversion therapy, including the cost of surgery, therapy, and medications, with $9.23 billion being the cost of services for the harms that are associated with conversion therapy, such as substance abuse and suicide attempts. Assessment and screening. So it is necessary to routinely screen LGBTQ patients for anxiety, depression, and suicidality. They should also be screened for alcohol or substance use, bipolar disorder, eating disorder, psychosis, and PTSD. General screening tools for the anxiety, depression, and suicidality include the PHQ-2, PHQ-9A, and the PHQ-9, as well as the Generalized Anxiety 7 scale, Anxiety Disorder 7 scale. LGBTQ treatment plan. We have pharmacologic interventions. The treatment options provided are based on first-line treatment recommendations for both adults and adolescents, depending on the age of the patient, obviously. Collaborative interventions. It is important for providers to connect patients with community resources and resources specific to the LGBTQ plus community. Psychotherapeutic options include cognitive behavioral therapy, dialectical behavioral therapy, mindfulness-based acceptance and commitment therapy, and transcranial magnetic stimulation, which is a non-drug, non-invasive treatment option for depression symptoms. Interventions specific to CBT include the EQUIP program, AFFIRM program, and Rainbow Sparks. Family therapy can also help to minimize the risks caused by family rejection and teach acceptance, thereby reducing the risk of mental health dysfunction and risk of suicide. And finally, our last population is the immigrant and migrant workers population. Since 2013, 19% of all migrants globally have concentrated within the United States. There are 40 million immigrants in the US, making up 24% of the total US population, including immigrants and their children. Epidemiology, the overall prevalence of depression and anxiety among migrant workers was 38.99% for depression and 27.31% for anxiety. Looking at economic costs, the average cost of providing insurance to immigrants is less than a US-born citizen at $3,800 versus $9,428. The average annual cost of healthcare for unauthorized immigrants was $1,629 and $3,795 for authorized immigrants. Immigrants to the United States generally have lower rates of mood, anxiety, and substance use disorders compared to the US-born population, with increasing risk of psychiatric illness, with longer duration of residence in the United States, and generational status. Service among US immigrants with a psychiatric diagnosis range from 5% to 40%. In studies that did not consider diagnostic criteria, the rates range from 3% to 6%. Immigrant and migrant workers assessment and screenings. These can be completed with the same screening tests as those general adult screenings or those for adolescents, again, depending on the age of the patient. The only difference would be to be culturally appropriate with the approach and the use of translation services to ensure appropriate understanding between the patient and the provider. Treatment plan remains the same as for non-immigrant adults for mental health disorders. The difference in treatment lies in being culturally competent in your approach to treatment, as well as the types of treatment. There are certain cultures where medication is acceptable, but therapy is not, and vice versa. Navigating treatment options is best with cultural competence, as well as collaborative care. This would be to use the translator for those patients who do not speak English or have English as their second language, to ensure that there is no miscommunication with the information provided and given back between the patient and the provider. Assessment across the board, you do want to rule out any types of other physical conditions that could be displaying depressive symptoms, and that can be completed with some standard lab tests, CBC, CMP, thyroid panel, so on and so forth. Thank you and have a good day.